Used to tell my postgraduates, don't trust on blood reports, don't trust on urine reports, trust your brain, trust your eye அப்படின்னுவேன். என்னடா ட்ரஸ்ட் யுவர் பிரெயின் அண்ட் ட்ரஸ்ட் யுவர் ஐ என்னென்னா, எனி சைல்டு இஃப் யூ டேக் அன் எக்ஸ்ரே, எந்த பீடியாட்ரிக் பிஜி எக்ஸ்ரேவை நல்லா படிக்கிறானோ he will not miss the diagnosis. அந்த எக்ஸ்ரே பார்க்கும்போது ஒரு ஹோலிஸ்டிக் அப்ரோச் எப்படி வேணும்னு கண்டுபிடிக்கணும். ஒரு பிராங்கியோலைட்டிஸ் வந்தால் லங்ஸை மட்டும் பார்த்துட்டு போகிறது தப்பு. யூ ஹவ் டு see the stomach, you have to see the diaphragm, you have to see the rectum, you have to see the bone, you have to see the subcutaneous tissue. You will be surprised to see bronchiolitis பாப்பாக்கு கடைசி ஒரு rickets இருக்கும் if you start seeing the x-ray. அதான் ஸ்பெஷல் அபவுட் ரேடியாலஜி இன் பீடியாட்ரிக்ஸ். இது வந்து வெரி யூனிக் ஃபார் பீடியாட்ரிக்ஸ். அதனால் 150 people are sitting here. If you are able to diagnose a x-ray very well, you are going to be a very good pediatrician. ஸோ நான் வந்து எப்பயுமே பெத்தாலஜியோ மைக்ரோபயாலஜி பயோகெமிஸ்ட்ரி ரிப்போர்ட்ஸ்லாம் ரொம்ப நம்புறதில்லை. கிளினிக்கல் எக்ஸாமினேஷன் ப்ளஸ் எக்ஸ்ரே. அந்த எக்ஸ்ரேயோட இம்பார்ட்டன்ஸ் என்னன்றதை ஐ திங்க் மேடம் இஸ் த ரைட் பர்சன் டு டெல் யூ டுடே, த நெக்ஸ்ட் 50 minutes session where you are going to see so many x-rays, how we can make so many diagnoses. மேடம் வந்து ரிட்டையர்ட் ப்ரொஃபஸர், பட் அவங்க நாங்கள் விடுறதுக்கு எனக்கு மனசு இல்லை, அதனால தான் நீங்கள் வந்து தான் ஆகணும். மேடம் கூட சொன்னாங்க, என்ன கூப்பிட்றீங்க டிபார்ட்மெண்ட்டில் தான், டிபார்ட்மெண்ட்டு என்ன சொன்னாலும் எனக்கு கவலை இல்லை மேடம், எனக்கு ஐ நீட் குவாலிட்டி. ஸோ குவாலிட்டி பர்சன் ஃப்ரம் ஏ குவாலிட்டி டிபார்ட்மெண்ட், ப்ரொஃபஸர் விஜயலக்ஷ்மி. ப்ளீஸ் மேடம்.
Good afternoon to everyone. Actually, I have to repeat whatever he said about X-rays. You see, we have to see the whole X-ray, which means you have to see, if you're going for a respiratory problem, you cannot ignore the bones, you cannot ignore the structures under the diaphragm. So you will have to see the full X-ray. So, starting with this, how will you see the X-ray? Now, we were taught to see from the periphery because the heart and lungs is not something that you will forget to see, whereas you will forget to see the other things. So we were always taught to start from the periphery. So you'll see the skin, the subcutaneous fat. Fat is usually a little lucent compared to the muscle plane. Then you will see the muscle plane, then you will see bones. Then as you come inside, you will see the lungs and the heart. Also look at the diaphragm, the cardiophrenic angle, the costophrenic angle. Remember, there will be a little bit of humerus that you can see on top, a little bit of upper end of the femur that you will see. You will see all the bowel loop patterns also. Now, when you come into the respiratory system, when you see lungs, there are two questions that you should ask yourself. Are they equal in aeration and are they equal in volume? Aeration means the degree of blackness, the amount of air that is there. Okay? So, when you see the heart, always you're going to see less of the left lung. The heart, about 1/3 of it can be to the right of the midline. Using that, you will know whether it is pushed or pulled, whether the mediastinum is shifted. So then you see the heart, and remember you should also see the bowel loops below the diaphragm. So, can anyone make some observation here? Anything which suddenly strikes you? Now if you see the clavicles, they're so widely spaced. This is a case of split sternum. So here you see, it is a diagnosis that, of course, it's obvious clinically. You will see that ballooning out of the upper chest with each breath. But this is how it will see. So you have to see everything in the X-ray. And can anyone even make out anything in this? Normally, this medial end of the clavicles, that is one step of it. Medial end of the clavicles should be equidistant from the midline. Now, can you see the clavicles? So, if that is the first step that you take to see the X-ray, you see that the clavicles are hardly seen. There's a little bit here. Okay, there's no clavicle on the right side, a little bit of clavicle on the left side. So, this is cleidocranial dysplasia. Okay, so we are not only looking at the heart and lungs. That's why these two X-rays. Okay, so this is our famous topic that, it's something very peculiar to the pediatrics. So you see what is wrong here. You see, sir, that both lungs are bilaterally, symmetrically white. This is just a normal for you to compare. And if you see carefully, you will see a very nice bronchogram, because this is respiratory distress syndrome. Air will pass freely into the airways. They are able to pass even to the tiniest airway in the periphery, but they cannot get into the alveoli. So you will see a very good air bronchogram even in the periphery of the lungs, which you normally don't. So this is a case of respiratory distress syndrome. So this child has also come with the respiratory distress. Day one, this child is come from. Now what is this? Now, is it respiratory distress syndrome? It should be bilaterally symmetrical white lungs. And it should be uniformly, no lung is spared. No? The full lung has to be white. But here if you see, there is a little bit of sparing. So now this child, you have two problems. You either it is pneumonia, congenital pneumonia, or it is just something very harmless like transient tachypnea of the newborn. Now, so how will you find out? You see an X-ray like this, you see the child is having respiratory distress. How will you find out? You just have to support the child and repeat an X-ray after 24 hours. You see, it's the same child. The next day, so look at the date, it's the next day. See, the lungs have cleared so well. No pathology will clear like this in 24 hours. So you're just left with the transient tachypnea of the newborn. Now this is respiratory distress syndrome. But here, this is a child with respiratory distress syndrome after at the end of a month. And you see that there is a ground glass opacities, both lungs. They are large. This child was treated but did not respond well to treatment. So now there's some interstitial inflammation, ground glass opacification, and also the heart is getting a little bigger. No, because this is because of bronchopulmonary dysplasia. Now we're talking about air. Air is black, and if a lung is white, it means it is because there is no air. So you see that we saw two lungs being white. Now we are seeing only one side being white. So there is no air here. This also, there is no air here. So we have two options. What do you think this is? Either it is consolidation of the whole lung, in which case you give medical treatment, you continue, or it is collapse of the lung. Collapse of the lung means you might have to do a bronchoscopy to relieve the airway. So this is a crucial decision to make on your part. Now how will you make this decision? You look for, I told you both lungs should be equal in aeration, equal in volume. Of course the aeration is gone. Now we have to see the volume. 1/3 of the heart can lie to the right of the midline. So do you see any heart here? The entire heart is gone to the left. I'm not seeing any heart to the right of midline. So that means there is a volume loss. So this is volume loss means collapse. So this lung is collapsed. Whereas here I do see some heart on the right side. The trachea is also fine. So there is no volume loss, no volume gain either. So this is consolidation. Now in consolidation, there is no volume change because the alveoli, which are supposed to be filled with air, gets filled with exudate. So there is no volume change. So this is just consolidation, this is collapse. Okay, so what do you think this is? Where is the heart? Not that this is heartless. The heart is probably on the right, okay? Probably. So where is the right lung? Can you see the air bronchogram? You can see the air bronchogram. Yes. So this lung is collapsed and has pulled the heart to that side. And then this left lung has to hyperinflate. It has to compensate. Now anything else you can see in this X-ray? See the NG tube? Where is it? Okay, this is in the esophagus, upper part of the esophagus of pharynx, and you see that the whole upper esophagus is so dilated. This is a case of esophageal atresia with a tracheoesophageal fistula. You see there's air in the abdomen, so there is a fistula. So these children also prone to all these collapse and consolidation and all that. So this is a case of TEFs. So remember, you have to see the whole X-ray. Now this is another X-ray, somewhat like this. No, you can see the heart is shifted to the right, but I can't see any air bronchogram. But if you see an air bronchogram, it is helpful. If you don't see, it doesn't mean anything. So I cannot see any air bronchogram. So I am left with a collapse of the right lung, or an agenesis of the right lung, or a hypogenesis of the right lung. So in such cases, you will always have to confirm with what? You can do echo, and you will see that the right pulmonary artery is absent or attenuated, and the right lung may be there, a small vestige of a right lung may be there. Now, here again, same thing, there is an opacity in the right. We saw a full lung, now we are only seeing a part of the lung, or one lobe of the lung. So here you see the right upper lobe, we are dealing with the right upper lobe. The right upper lobe is white, so there is no air there. Our only options are consolidation or collapse. So how will you see? Trachea you will see. Okay, so let's see the trachea. See, the pointer cannot be seen there. Okay, so you can see that the trachea is shifted to the right. Okay, a little bit of shift to the right is normal. Okay, now so I'm telling you it's almost normal. So search for something else. You see the minor fissure is sort of arched, it's pulled up. Here you see the minor fissure is just going straight. No change in volume here. Here there is a reduction in the volume. So this is collapse, and this will be consolidation of the right upper lobe. Anything else you see in this? Coiling of the NG tube. So this again is esophageal atresia with a tracheoesophageal fistula. So you saw both lungs, you saw one full lung, you saw one lobe of the lung. Here this is sort of patchy. Okay, patchy areas of whiteness. So those areas don't have air in those alveoli. They are probably filled with exudate, transudate, blood, whatever. They are filled with some fluid. So here there are patchy areas of consolidation. So what do you think this is? This could be pneumonia. This could be pneumonia. But what is the, if you look carefully, you will get an answer. Now see, there is a fracture here. Okay? There is a healed fracture here. So what is this? This is battered baby. So this lung will be contusion. This will be lung contusion. Okay? So X-ray wise we cannot tell whether it's pneumonia or injury or just pulmonary edema. It's very difficult to say. But one thing we know is the alveoli are filled with something other than air. So here we have a clue that this is because of battered baby. And then you see fractures of varying ages. This is due to, this is a clue for battered baby. Okay. So this one, you see that we finished with whiteness, now we are coming to black. So there's a lot of blackness. So that means there is lots of air. Okay. So the air is either within the lung or within the lung when it is emphysema, or it's in the pleural cavity, which means it is pneumothorax. So this is pneumothorax, yes. Why? Because there are no bronchovascular markings. And then you can also see the compressed, collapsed lung. So here, just to show you, there is more air here. So it's either within the lung or in the pleural cavity. You search for bronchovascular markings. They are present or absent? Present. So this is an emphysema. Okay. Now, see, there's so much emphysematous that this part is herniating across the midline, pushing the heart also to the right side. Now, this could be emphysema. Now, which part is emphysematous? This is only one lobe is emphysematous. So, if you want to call it congenital lobar emphysema, you have to see the compressed other lobe. You have to see the other lobe before you call it a lobar emphysema. So, here you see this is the, you see crowding vascular, the bronchovascular markings are sort of crowded because that lobe is compressed by this emphysematous lobe. So, this is CLE, left upper lobe. So, commonest lobe to be involved will be left upper lobe. Next. So we've got, okay. So, we saw more air within the lung, we saw air in the pleural cavity. Now, this is air in the mediastinum. Now, always the, yes. Now, always the thymus is flush with the heart. So, it cannot be seen separately. That's why we call it a cardiothymic shadow in children. So, if there is air, it lifts the thymus away from the heart. You can also see some subcutaneous emphysema here. Okay. So, this is called the spinnaker sail sign. Okay. This large thing which blows out in the wind is called a spinnaker sail. So, this is the spinnaker sail sign. Now, there's also another sign. Normally, if you see the diaphragm and the heart cannot be seen separately. But here, if there is air, if there is pneumomediastinum, then you see that the diaphragm is seen separately from the heart. This is called a continuous diaphragm sign. So, this, again you see this portion is very black, and if you see there are bronchovascular markings. So, this is emphysema. But you have to see the other lobe. So, this is middle lobe emphysema. This is congenital lobar emphysema of the middle lobe, but you have to see the other lobes. That is how CT comes in very handy. Now, if you see here, this is the compressed lower lobe, right lower lobe, and this is the compressed right upper lobe. Now, if you can see it, you will see it very carefully. This is the compressed lower lobe that is seen posteriorly, and this is the compressed upper lobe that you can see. Okay. So, this is CLE. Now, talking of bronchovascular markings, normal bronchovascular markings should be if you see the normal bronchovascular markings, they show a nice dichotomous branching. Now, in the body, that is the rule, even vessels, everything will show a normal dichotomous branching. One will divide into two, each one will divide again into two. So, this sort of normal bronchovascular markings is something that you have to search for. But if you see here, this whole lung, this is extra black, so there is a lot of air here, and you see the bronchovascular markings do not follow that dichotomous branching. They sort of haphazardly thrown here and there. So, this is a case of congenital cystadenomatoid malformation or congenital airway malformation. You see here, the markings are very haphazard and not following the normal pattern. Here also you see, normally in the periphery you must not see any vascular markings. You won't see any vascular markings. But here you see thick vascular markings in the periphery of the lung. So, all this means it's congenital pulmonary airway malformation. So, what do you think this is? Now, this looks like pneumothorax, right? You can see that this looks like the edge of that lung which is compressed, and this looks like pneumothorax. Now, if you look carefully, you will see some vascular markings. The trick is you have to search, even if you see one bronchovascular marking, it is lung. It is not pleural cavity. So if you see carefully, you will find one vascular marking here. So this is just a skin fold. Like children have very soft abdominal and chest walls. So when you hold them firmly against that cassette, you can fold the skin. So it will give you an impression like this. That is, you will think that it is pneumothorax, but it's actually a skin fold. See, you can have multiple skin folds, and you see skin folds will go into the abdomen. Pneumothorax will not go into the abdomen. So all these, if you really are in doubt, you can always repeat the X-ray and see. And you will find that the fold disappears or fold will come in a new place. So if you're not careful about this, you will end up putting a ICD for this. So you must know this is a pitfall in diagnosis of pneumothorax. We saw this. This is CLE of the left upper lobe. Now you see, what do you think is wrong here? Now this is a very subtle finding. See, normally only 1/3 of the heart should be to the right of the midline, but here a little more of the heart is on the right. So there is some increase in volume of the left lung, which is a very subtle finding. Child has come with respiratory distress. Children will come with respiratory distress for whatever in the lung, whatever problem in the chest, they will come with respiratory distress. So if you see here, there is a mild shift in the mediastinum. So there is increase in volume of the left lung. This is whole lung is involved. So this is obstructive emphysema. Here you see the whole lung is emphysematous, but the reason is a destroyed right lung. So this is a compensatory emphysema. And here you see that both lungs are emphysematous. You see both the domes of diaphragm are flattened out. So both lungs are emphysematous. This, of course, we will see a common finding in children, bronchial asthma, electrolyte problems. So this is bilateral emphysema. And bilateral emphysema can also be seen in a central foreign body. So if there is a central foreign, of course, now bronchoscopy is very quick. Immediately the child is taken for bronchoscopy. But in those days we used to do fluoroscopy. Normally when you take a breath inside, the diaphragm will come down. And when you exhale, the diaphragm will go up. In fluoroscopy, if you see in a central foreign body, the reverse will happen because of air trapping. What do you think this is? Left lung is emphysematous. It's pushed the heart, no? The heart is on the right. This is left only, okay? So the heart is gone to the right. So what will you call this? Now what about the right lung? Now look at the right lung. Right lung is there, no? It's not that it's not there. The right lung is very much there. We can't see any other abnormality. Right lung is there. We can see a little bit in the periphery. But the left lung is emphysematous for some reason. And it's see the lung is crossing the midline. Now, this is due to hypogenesis of the right lung, or hypoplastic right lung. So in which case, if you see an echo, you can see that the right pulmonary artery is very thin. It's so small and attenuated. It's because the right lung has not developed. There's only a little vestige of the right lung. So this is, again, this is a hypoplastic right lung, and you have to confirm with an echo. You got little arrow marks there. This is the boot-shaped heart, and you see the concavity in the where the main pulmonary artery should lie. So this is tetralogy of Fallow, okay? And if you see here, this is a right aortic arch. Now, how do you diagnose a right aortic arch? You have to look at the trachea. The trachea, see, you see this impression on the right wall of the trachea. Normally, the trachea is a little to the right, no? That's because the aortic arch is on the left. So here, the aortic arch is on the right, so the trachea is indented on the right wall is indented. So this is a right aortic arch, so this is tetralogy of Fallow. Here also you see some opacifications, almost bilateral symmetrical, more in the center. This is pulmonary edema. Now, if the heart was big, we'll easily diagnose pulmonary edema. But here the heart is not big. This is case of myocarditis due to scorpion sting. There's no time for the heart to become big. But the heart is not working well, and this is the pulmonary edema. This is just to show you how pleural fluid, what pattern you will get. See, this is the pleural fluid which goes from this. Remember, this is an erect film. You see the air fluid level in the fundus. Erect film, this is how the fluid travels up. Now, another pattern is a B-shaped pattern, a double hump like this because of the presence of the fissure. So, this is how pleural fluid will be. What do you think this is? Miliary TB, yes. You see multiple nodular shadows. Oh, the full lungs are involved because this is a hematological shower of bacilli. So, no part of the lung is spared. The entire lung is involved. You see multiple nodular lesions, and all those nodules will be of the same size because it's a shower. They were born at the same time, so they will all be uniformly the same size and multiple miliary shadowing. And in addition, this child also has a large cavity. What do you see which is unusual? Which side of lung, which lung is blacker? Okay, so the idea is, first thing you have to see is that it's equal in aeration and equal in volume. That will give you a nice clue how to proceed further. So you see that this lung is blacker. So it is, bronchovascular markings are present. So this is emphysema. Okay, this lung is emphysematous. Now, why is it emphysematous? If it's the whole lung is emphysematous, then you think of a foreign body in that airway. Or if one lung is destroyed, you think this other lung is trying to make up. So you think, so why is this lung blacker? Now, if you see here, there's another wedge-shaped structure here, close to the spine. This is a collapse of the left lung, left lower lobe. This is a collapse of the left lower lobe, and this other lobe is trying to compensate. Here, this is a collapse of the right lower lobe due to a foreign body. Okay, it's an opaque foreign body, so it's easy for us to see. So, if you see a wedge-shaped structure close to the spine, and you see the volume here, this volume is so little, the lung is that lobe is totally collapsed. Here, there is a volume loss. Is there a volume loss? See both domes of diaphragm. The diaphragm will be, the left diaphragm is going to be a little lower. The 2 spaces is okay. Difference of 2 spaces is okay. Here if you see, the difference is quite okay. But this side is blacker because it has compensated so much so that the domes of the diaphragm are quite okay. It's quite normal. Here you see, the domes of the diaphragm are again within normal limits because I said 2 spaces are okay. But what is other, there should be a sign of volume loss. Then only I will call it collapse, right? Search for signs of volume loss. See this interspace. See this interspace. There is a crowding, no? Okay, there is a crowding. Then look at the heart. More than 1/3 of it is to the right. So definitely there is a volume loss. So I will know that it is only a collapse of that lobe. What has happened here? What has happened? Where is the ET tube? ET tube is preferentially ventilating the right lung. Okay. So what has happened to the left lung? The left lung is collapsing because it's not getting ventilated. Now here you see ET tube is in the right lung, and this lung is getting overinflated, because so an X-ray will also show you the correct positioning of the ET tube. So we finished air, now we are coming to whiteness. We finished black, now we come to white. Entire hemithorax is white. So what is it? Pleural fluid, okay? Gross pleural fluid. Let's call it fluid because we don't know whether it is exudate, we don't know if it's a malignant effusion, we don't know. So we'll just call it fluid. So this is gross pleural fluid. Now will a mass also be white? Mass will also be white. Okay, so, but we'll call this gross pleural fluid. Now here, if you see, this is not completely black, somewhat grey. So this is a mixture of air and fluid. So what is this? Pyoneumothorax. Okay, that is one condition, one very important condition for pediatricians. This is pyoneumothorax. You see the bubbles here. Okay, so there are air, and you see the costophrenic angle is sort of blunt. So there is fluid also. So this is air and fluid in the pleural cavity. So this is grey in color, right? This grey. So this is a mixture of air and fluid. So what is this? No, this can easily be mistaken for pyoneumothorax because it's grey, no? This is actually a case of delayed diaphragmatic hernia. That delayed diaphragmatic hernia is there is a hole in the diaphragm, but it is sealed by the stomach, and the child grows up normally. Then, due to some fall, some trivial injury, something so trivial that they won't even tell you, they won't think it's important for you to know. Suddenly, the stomach, because of that sudden small trivial fall and a sudden exhalation that the child does, the stomach gets into the chest. Once it gets into the chest, okay, no problem. The child picks herself up, then comes home, eats, then the food gets into the stomach. So the stomach distance, then pent up secretions, the food, everything, stomach distance, and the child gets dyspneic. So after that only they will come to the hospital. So if you're not aware of this condition, you'll have to think of this condition. See, the X-ray sometimes gives you the diagnosis, and sometimes it prompts you to think further, to do something that will help you confirm. So if you're not aware of this condition, see, an ICD has been put, thinking it's a pyoneumothorax. Now what you should have done is put an NG tube, and you will see that the NG tube is coiling in the chest. So which means this is the stomach. So the stomach has gone to the chest. This is a delayed diaphragmatic hernia. This is just to show you, sometimes the thymus will give you the impression that maybe there is a mass. So in that case, you can always do an ultrasound. And it's very easy. In just 2 or 3 seconds, you will know that you're dealing only with the thymus. So this child was dyspneic, had respiratory distress even at rest. You see some sort of ground glass opacification. Here you see this is a case of interstitial lung disease. This child also came, and what do you think this is? The child came with, the child was unable to walk, or rather get onto the 3rd floor or 5th floor where her classroom was. So the pediatrician saw, and then we took this X-ray and we said, okay, fine, everything is normal, you go home. Then again she comes back with the same complaint, and then we said, okay, it's time to do a CT. And see, what does CT show you? You can see ground glass opacification and saw small blebs of air forming. This is also interstitial lung disease. Somehow the interstitial lung disease incidence is rising. And so if the chest X-ray is normal, but the clinical picture, you're not satisfied, then it calls for a CT of the chest. So you see number of small cystic areas. So what is this? Okay. Now, what is the difference between this and this? Mediastinal shift is the difference. Okay. Mediastinal shift means something more is there. That is why it is getting shifted. So here, there is no shift, but there are lots of cystic shadows just like a diaphragmatic hernia. No shift, these are just abscess. So they are not a surgical problem. You don't have to send to the surgeon. So this sort of thing you should be aware of. And see here, there are lots of cystic shadows. There is a gross mediastinal shift. The heart is on the right side. And you see that the stomach alone is there. The rest of the loops are up in the chest. So this is, what do you think? This is eventration, okay? Because, see, however flimsy the diaphragm is, it will never touch the apex. And the stomach always travels with the dome of the diaphragm, always. So this is eventration of the right and this is eventration of the left. What do you think this is? You see one shadow in the cardiophrenic angle, okay? Rather vague, right? For all you know, it's pneumonia or whatever. But when you see something in the cardiophrenic angle, always be careful. Because this is one site which is the site for many conditions which are very peculiar to a child. So this is some hernia. So your first thing is hiatus hernia. Because hiatus hernia is very common. But here this turned out, which we did give a spoon of barium. But you see, I'm not sure whether this is stomach. So we did give a spoon of barium and we knew that the stomach was okay. So it's not hiatus hernia. So then this is a barium enema that we've done and showing the transverse colon is in the chest. So this is a Morgagni hernia. In Morgagni hernia, it's an anterior defect. So the transverse colon only gets into it. What is this? Air fluid level around abscess. Okay, this is just consolidation. Okay. See the cardiophrenic angle has a small bump. This child is coming with recurrent respiratory infection. Just one routine X-ray and you see one small bump here. What could that be? Cardiophrenic angle, you must think of hiatus hernia. All that you have to do is give one spoon of barium and you'll know that this is the stomach. Okay. Now coming to abdomen, we'll go fast. Now how do you see the abdomen? You see that you look for certain air shadows. One is stomach. The fundus of the stomach will be in that place only. It won't shift. You will always get to see it there. The next thing is the transverse colon. And the third pocket that you see is the rectal air. So these three pockets of air you should see. Then in between you will get other things like small bowel loops. Okay, so this is the stomach. Then I'm searching for the transverse colon. And you see one claw-shaped shadow. What is this? Intersusception. Okay, this is the colon. This is transverse colon and this is the intersusceptum. So what is this? You see, I cannot see the stomach, so maybe the child has vomited. Okay, I cannot see the transverse colon. Okay, now can you see the rectal air? No rectal air. And in between, I'm seeing lots of dilated small bowel loops. So what is your diagnosis? Small bowel obstruction. Here you're seeing no rectal air, stomach is there, some dilated small bowel loops, something is wrong. What do you think is wrong? There is some obstruction. What is the cause for the obstruction? See all this? This is ascariasis. One ball of ascariasis that is causing the small bowel obstruction. Can anybody say? You see air under the diaphragm? Okay? Then this is the football sign. That is, the falciform ligament gets opacified with the air on both sides. So you see it as a white line in the center. Okay, then loss of liver whiteness. That is why you percuss, no? And you see the percuss over the liver in case of pneumoperitoneum. The same way, this is a loss of liver whiteness. And then this is the Wriggler sign. Air inside the bowel and air in the peritoneal cavity outside the bowel. So the wall of the bowel is very white. This one, Is there any air in the abdomen? This is pure esophageal atresia. This one, coiled NG tube. So there is an esophageal atresia, but there is air in the stomach, so there is a tracheoesophageal fistula. Air in the stomach. Any distal air? Distally, is there any air? No. So this is pyloric atresia. Okay. Always look for distal air. Where the air stops, that's the place of the atresia. So this is pyloric atresia. This one? What? You see a dilated stomach, you see dilated duodenum, but look for distal air. That is the rule. Look for distal air. Is there any air distally? Yes or no? Look at the rectum. Look at all this. There is air, no, distally. So it's not an atresia. So this is malrotation. Now this is far more common than duodenal atresia. But clinically they will come in the same way. So this is only malrotation. Okay. See here, you see stomach, duodenum, no rectal gas. So this is duodenal atresia. Now in malrotation, you look for the DJ flexure. DJ flexure should be to the left of L2. Here you see that it's overlying the spine. You can also see in an ultrasound, you will see that, see this is the superior mesenteric artery, this is the aorta, and this is the vein. Normally the vein is to the right of the artery. In malrotation, the vein goes to the left of the artery. This again is to just show the whirlpool sign. So you see the stomach, the duodenum, a little bit of jejunum, so the atresia is in the jejunum, jejunal atresia. And this one will be more loops of dilated bowel loops are there, but no rectal gas. Lots of loops are there, so I will call it ileal atresia. Here, look at this distended abdomen, but hardly any loops, no? Hardly any air-filled loops. Distended abdomen, but not much air, paucity of air. You must think of meconium ileus or meconium peritonitis. Here, this meconium peritonitis, there is meconium in the peritoneal cavity which has got calcified, so that this is also meconium peritonitis. And you will, barium enema will show a very small unused colon with, look at this, meconium plugs, okay, which are showing as filling defects. So this is meconium ileus. Now, however, whatever sophisticated tests come, we still have to rule out Hirschsprung's disease. You still have to do barium enema. Child comes with constipation, you have to do barium enema, and you look here, you look for the transition zone. This is the rectum, and then suddenly this colon bulges out. So you must look for the transition zone to diagnose a case of Hirschsprung's disease. Here, if you find uniform dilatation of the entire colon, it is only habit constipation. What do you think this is? Achalasia cardia. Okay. This is a long segment stricture due to corrosive poisoning. This is PUJ obstruction. What do you think this is? Posterior urethral valve, a dilated posterior urethra, very thin anterior urethra. Now, we just skip through the abdomen. Okay. Now, what do you think this is? Short stature, child comes. Okay. If you look at the ilium, now the first thing that we see is the pelvis. If you have a problem with dysplasia, if you have a dysmorphic child, then always don't look at all the bones, because it will only confuse you. Only look at the pelvis first. Now looking at the pelvis means looking at the ilium, the ischium, the pubic bone, a little bit of the upper part of the femur, also a little bit of the lumbar spine that is included. So that is what it means by looking at the pelvic X-ray first. So when you see this ilium, it is square. So this is most likely achondroplasia. But a square pelvis does not mean achondroplasia alone. There are other many conditions with the square pelvis. So then you have to look at the interpedicular distance. Normally, interpedicular distance will widen as you come from L1 to L5. Here you see that they are actually converging. Sometimes they can be parallel, but they will never widen as in the normal. So this is a case of achondroplasia. Now this is achondroplasia for you to compare. See, this also is a square ilium. But if you look at the IP distance, are they converging? They look normal, no? So this is not achondroplasia. So what is it? If you look carefully, this is a small infant, and you look that the upper femoral epiphyses have appeared. Not only appeared as a small dot, they are nice and round, they are big and round. So this is a case of asphyxiating thoracic dystrophy. Depending on how short the ribs are, these child will live a little longer. If the ribs are very short, they are going to die of mechanical respiratory distress. Now look at this. This is normal. See how far forward the ribs come. Here they are stopping midway itself. So the ribs are short. Now this is the same asphyxiating thoracic dystrophy. Now if the child lives longer, we call it June syndrome. Okay. Now this ilium is square. This ilium is also looking square, but IP distance is okay, and the upper femoral epiphysis is not nice and round. So this is not asphyxiating thoracic dystrophy. This is not achondroplasia. So this is something else. So you will have to look for other features. Look at this metaphysis. The medial part of the metaphysis will have a slope. That is peculiar to Ellis Van Creveld. And in addition, you have a mesomelic shortening. And Ellis Van Creveld children also have polydactyly. About 75% of them will have polydactyly. But some normal children will also have polydactyly. So how will you differentiate? You see this capitate hamate fusion. Capitate hamate fusion again is very common. In almost 80% will have capitate hamate fusion. Or if they are not fused, they will be placed very close to each other. In the normal, it will be, capitate hamate will be normal. See, because the short ribs, the chest is sort of bell-shaped. This child also, if you see, the ilium is square, but the vertebrae are very much flattened. And you see, this is a postmortem X-ray. The lungs are not aerated, see. So this is a case of thanatophoric dysplasia. Extremely short limbs, very short, so that, and they're bent like this, like a telephone handle. And see the extreme flattening of the vertebrae. This again, this is quite a new case. Someone might recognize this. Also, you see it's a square ilium, but if you see the femur, they are like so expanded on both sides. The metaphysis is so expanded. It's likened to a hunting axe. This is a metatropic dysplasia. Now coming to another type of ilium, we saw square ilium. Now we see this lower part of the ilium is hypoplastic, pointed and tapering. This is a feature of mucopolysaccharidosis. But radiologically, we can only differentiate between two types. That is Morqueus and Hurler's. If you see here, this proximally the metacarpals will show a dysplasia. They will be hypoplastic, they will be tapered, they will be narrow. This is a feature of mucopolysaccharidosis. But in Morqueus, the middle constriction is maintained as in the normal. In Hurler's, the middle constriction is lost. That's the bullet-shaped metacarpals. Now coming to the spine, you see middle beaking is a feature of Morqueus. That is, the beaking is right in the middle of the anterior surface of the vertebrae. The beaking is in the inferior part of the anterior surface. Coming to the bones, you see that the shaft of the bones have lost their normal, the shaft has to be thin and both the sides of the limb bone should be expanded. Here if you see, the bone is sort of cylindrical because the shaft has expanded. And why is it expanded? Because of a very exuberant periosteal reaction. This is the case of mucolipidosis. Now here also you see the shaft is expanded because of a lot of periosteal reaction. All the bones are involved. So you must not think of it as a dysplasia. Here if you see, there's a chunk of bone that is removed. You can see the corner of this screen. You can see that there's a chunk of bone that is taken off. Normally you see that Wimberger sign in the upper end of the tibia. Sometimes you also see it in other areas. So this is a case of congenital syphilis. So you must look at the metaphysis. Look at the metaphysis here. Quite okay. The bone density is quite okay. Here you see lots of lytic lesions. So there's a periosteitis and there's a metaphysitis. Okay, spotter. Chondrodysplasia punctata. Okay, see stippled epiphysis. Here you see this thin shaft is thin, but the metaphysis is so expanded, no? So this is Pyle's disease. Here you see that the diaphysis is expanded. This is diaphyseal dysplasia. This is a type of metaphyseal dysplasia. This is a type of diaphyseal dysplasia. See these bones, they are showing multiple fractures and they are bent. Multiple fractures. What is this? Osteogenesis imperfecta. Now, so let us see the bone density. Osteogenesis imperfecta, bone density should be less. Look at the bone density where there is no fracture. Look at the bone density here. Nice cortex, nice medulla. Okay, here you see that the cortex and medulla are very porotic bones. So here you must think of battered baby syndrome again. Okay. One more clue for that. Look at the ribs. Ribs will be nice and normal in battered baby. See, look at the ribs where there are no fractures, where there is no callus. You will see that the rib is normal in thickness, normal thickness of the ribs. Here you see the ribs are so thin. This is osteogenesis imperfecta. This is just battered baby. So this is osteopetrosis, yes. And the other dense bones disease is pycnodysostosis, where there is terminal acroosteolysis. The terminal phalanges are showing lysis. Okay. Here in osteopetrosis, the terminal phalanges will be intact. Another thing is that in pycnodysostosis, this angle of the mandible becomes obtuse. In osteopetrosis, the angle is normal. Now, why you should differentiate between the two is, these children do quite well, whereas these children don't do quite well. So what is your diagnosis for this? What is your diagnosis for this? No clavicles, no? So this is cleidocranial dysplasia. Okay, but I always say look at the pelvis first, look at the pelvis. So you need one feature in the pelvis. Here you see the pubic bones are not seen. It's not that they are not there, they are there, but they are not ossified. So this is a feature of cleidocranial dysplasia. See, in ectopia vesicae also, you will have this gap here. But the pubic bones are very well ossified. It's only that they are separated. Okay, here the pubic bones are not ossified. Okay, what is your diagnosis for this? You see this sort of cupping, fraying. Okay, so you think it's rickets. Okay, Now, see here, this femur is involved, this femur is involved, but the tibia is not involved, no? Rickets cannot spare some joint and go and involve another joint. So this is only metaphyseal dysplasia. This is very common. For us, it's very common because the child doesn't really suffer much. They'll be a little short, that's all. So this is metaphyseal dysplasia. They will have expanded wrists, they'll have rickety rosary. They will look just like rickets clinically. See, this is rickets where you see that both tibia and the femur are involved. All the bones will be involved. This I just brought it because you probably won't see this in your life. That's why. This is scurvy. Now look at all for the signs of scurvy. See that pencil-like thick whitening of the epiphysis. Okay. Then you see that here. You see this subperiosteal hemorrhage which has lifted the periosteum. Okay, and here also you see the zone of provisional calcification is very much there. In rickets it is lost. Here zone of provisional calcification is there. The cartilage is fine. The cartilage gets calcified, but the osteoid is not formed. So there is no ossification. That's why you will have a below this provisional calcification you will have a scorbutic zone. You will have some lytic areas here. And this is that Pelkin spur. Now sometimes both these children, only 2 children I've seen with scurvy, they are neglected children. They are mentally retarded, neglected children, but then giving care for them is very difficult. And if they're going to keep on crying because of bone pain and they cannot be handled by the caretaker, then it's very difficult. So it's good if you treat them. It's good for the caregiver also. This is normal for you to compare, and this is abnormal. If you look carefully, where are can you see the anterior ends of the ribs? Can you see the anterior ends of the ribs? Normally they are not seen. You won't, your eyes won't even find them. Here if you see the anterior ends of the ribs are just standing out. You can see them. Then you see that there's a dense metaphyseal band. So that's why this is important to see the upper end of the humerus also. So what is this? Heavy metal poisoning. But if you are, it's always easier in the long bones. You see this dense metaphyseal band. This is heavy metal poisoning. This is just normal for you. We come to the end of this. I hope you found it useful. Thank you very much.